Oh, okay. So good evening. All right. Well, can you hear me?
Yes.
Okay. All right. Let me look up something real quick. Okay. So good evening, everybody, and welcome to our first town hall meeting of the year. This, as you know, is a joint collaboration between the Jagils Global Institute and 𝘼𝙗𝙗𝙤𝙗𝙗𝙤𝙮 𝘼𝙗𝙗𝙗𝙗𝙗𝙁 Association North America. And we've done this in the past where we had presentations on various topics. And this year we decided that, you know how usually at the beginning of the year, everyone makes like, health resolutions and things like that. We decided that as we begin the year, we should actually try to focus on our health. And, if we're healthy as individuals, we'll be able to contribute meaningfully both to the society and to 𝘼𝙗𝙗𝙗𝙗𝙗𝙗𝙗 Association, to Jagils and everything else that we belong to. And we are so honored and privileged tonight that the very first topic that we are starting with is actually colorectal health. I'm not going to go much into the topic because the doctor himself is here. He will do justice to it. But I just wanted to introduce him briefly. Dr. Nunoo, if you saw from the introduction, is a proud Santaclausian. And if you saw his picture, I mean, the first thing you see is the typing, Adisco's typing. He is a true son of 𝘼𝙗𝙗𝙗𝙗𝙗𝙗 College. And when I contacted him, I just want to say a big thank you to him. He's a very busy man. But as soon as I approached him, I mean, he was so kind and, open to organizing this for all of us. He works in that field and he knows how important. Hello?
Yeah, we can hear you.
Okay. I mean, he knows how important this field is. And he was so generous with his time that he agreed to, share with us this Friday night. So without going into much, and one more thing I want to add. As Ghanaians, and even as Santaclausians, we have a lot of treasure that we are not unearthing. You will be amazed. I took the time when he sent me, because I asked him for his info to, create the flyer. The link that he sent me, I took the time to read the reviews. And you'll be amazed the number of people whose lives he's impacted. I'm not talking about, one of those things where you call your Ghanaian friends and you tell them to go and post something nice on your page. You can go on there when you have the time yourself. I mean, people from different, ethnicities, mostly Caucasians, actually, like people from America that he's positively impacted, literally saved their lives. And we are so honored and privileged to have him tonight, especially to present on this very topic, which, I mean, we take for granted because for the most part, we don't come into contact with it. But most of the people who deal with this find out the hard way how, awful it could be. So without wasting much time, I have the privilege and the honor to introduce our fellow Santaclausian and Dr. Robert Nunoo. Thank
you. Thank you very much. That was a very generous introduction. I'm going to start by sharing my screen so that we can, all see what I'm going to talk about. I'll start off by saying that I have to start at the beginning, not the end. I was very privileged, to be approached to ask, to do this presentation. My initial thought was that I was going to do a presentation for a few Santaclausians who, I've known for many years, and we're going to have this, very nice and light conversation about colon and rectal cancer. But I found out not too long ago that people who were not even connected to Adisado College had received the flyer via WhatsApp, and it was making the rounds. So all of a sudden, it's gone from a little casual conversation amongst friends to I actually had to put together a presentation, but I think it was good. Anyway, I hope you all, learn from this and also enjoy it. There are a few graphic pictures. So if your stomach is soft, please look away when some of these pictures come up. Anyway, so my name is Dr. Robert Nunoo. I'm a colorectal surgeon. I'm based in North Carolina. I work for WakeMed Health and Hospital. I'm also associated with a facility in Ghana called Pleasant Medical Center, which was founded about 1.5 years ago. I'll start off by saying thank you to Dr. Winter, who introduced me, and also to Dr. Samuel Jacobs-Abbey of Jagils for putting all of this together. I'm part of Pleasant Medical Center, so they also sponsor me in some of these things. So I'll start off by saying a few words about Pleasant Medical Center, and that is because there's some important information there that concerns the talk we're going to have today. So Pleasant is a facility that's in Ghana. It's based out of Ashiaman. They treat general medical patients, but we do specialize in digestive diseases. And the plan is for me to go to Ghana every quarter to actually participate in the care of the patients there. We have a functioning operating room that offers laparoscopic services. So the main reason why I'm pushing this is the next slide, this slide. So between April 21st and May 5th, I'm going to Ghana with a group of surgeons from here to do free surgeries at Pleasant Medical Center. We're planning to do about 50 free surgeries, which will be paid for. And so if you know anybody who lives in Ghana who you think might benefit from any of these surgeries, please, I'll put up a flyer where they can. This is just our facilities. This is our website, pleasantmed.com. You can contact us through there. Or this is a flyer that's made for WhatsApp, and it gives you all the necessary information. They do have to go there to get screened to make sure that they're actually fit for the kind of services that we'll be coming to provide. So I'll leave this flyer at the end. I'll give it to Samuel, that's Dr. Jacobs-Abbey, if you can put it up, at the AOBA website or something, for people who may be interested. Okay. So now let's talk about why we are here. We're going to talk about colon health, mainly colorectal cancer. But I've added a few other things that I think would be interesting. Let's start off with a little bit of anatomy. So this is sort of what your colon looks like. Let's say your head is somewhere here. When you eat, it will go through the esophagus, get into your stomach, and then your stomach contains some acid, and the acid has one function, that's to actually sterilize the food that you eat. So it will kill off bugs and other bacteria and other things that you've eaten. Then the food moves from the stomach into the small intestine, which is really where all the digestion and absorption takes place. So you cannot live without your small intestine. You need enough small intestine to survive. And when the food is digested and all the nutrients have been absorbed, it gets into the colon. And this is the colon. Goes all the way around down to the rectum and the anus. And the colon has, a few functions, but its main function is to turn your liquid waste into solid, because there's a lot of fluid that's coming out. And if it's not turned into solid, people get dehydrated, or you can get dehydrated. So you can live without your colon because it doesn't really absorb much food or nutrients. It does a little, but it's mainly the small bowel that does everything. But you cannot live without your small bowel. You need enough small bowel to survive. On average, the adult has about 400 centimeters of small bowel, and I would say you need at least 150 or 200 to be able to live. If you have less than that, you will not absorb enough nutrients, and it's not compatible with life. People try to do small bowel transplants, but it's not always successful. This is a little more of the anatomy. This is what the colon looks like, isolated. This is what the rectum looks like. And then down here is the anus. This is where hemorrhoids and a few things appear. I will talk about this as well. So let's start off with colon cancer. Colon cancer, it's not very common in Ghana, but it's definitely on the rise. One of my classmates who went to Adisado College with us, I'm sure you all know him, 𝘼𝙗𝙗𝙗𝙗 𝙤𝙗𝙗, passed away from colon cancer. I also have another classmate that went to Tech for 1 year for medical school, and one of the doctors who graduated from that class, Dr. Collins Frimpong, also passed from colon cancer. And so a lot of us know about somebody with colon cancer, and colon cancer is on the rise. Anyway, today I'll be talking about colon cancer. I also talk about diverticulitis. I'll touch a little bit on inflammatory bowel disease. I'll talk about our gut microbiome, anal cancer, and then a myriad of anorectal diseases like hemorrhoids, fissures, abscesses, fistulas, and condylomas, and etc. So colon cancer is actually, the incidence in America in general is going down for patients who are 50 and over because they've been screening, but it's actually rising in the younger patients. That's people who are less than 50. The estimate for this year is that there'll be about 107,000 new colon cancer cases and about 46,000 new rectal cancer cases for this year, 2023. In other words, about 4.4% of men in America would develop colon cancer or colorectal cancer, and about 4.1% of women in their lifetime, that is. What causes colon cancer? It's a certain portion of it is genetics. We know that about 10% of colon cancers are caused by genetics, that people inherit the trait from either their mother or their father, or sometimes both, and that can lead to them having colon cancer. And 90% of colon cancers are what we call sporadic, which means that people just get them, and we really do not know why. One thing that we know for sure is that it's environmental. And how do we know that? And that is because if the incidence of colon cancer is very low in places like Ghana, and it's a lot higher in the US, that if you move from Ghana and you come and live in the US for 10 years, your risk becomes the same as the average American. Your risk is not the same as the Ghanaian back home. And so there is something in the environment we know that triggers these things. The same thing, and it's not just colon cancer, the same thing as we know about breast cancer, in that the studies that show that the incidence of breast cancer in, for instance, Japan is quite low, but for Japanese women who move to America within 1 generation, and sometimes even less than that, their risk is just as high as the average American woman. And so there is something in the environment. It could be something in our food, something outside, something that we come into contact with. We just do not know these things, but there are many studies trying to find that out. So colon cancer, the picture on the right, that is what colon cancer can look like. The picture on the left is a polyp. So this is why screening is important. So whilst the colon cancer is malignant on the right and can kill you, the polyp on the left is benign. And if you get your colonoscopy and we find this polyp and we take it out, it will never become the cancer and you get to live longer. So that is why screening is important. So if you're 45 and over and you're watching this, and you've never had a colonoscopy before, Talk to your GI doctor, talk to your primary care doctor, and make sure you get a colonoscopy, because the picture on the left is benign, the picture on the right is malignant, and the malignant means it's cancerous and it can kill you. Okay. So what are the signs and symptoms of colon cancer? There's rectal bleeding, which means you see blood in your stools. Sometimes the stool doesn't look red, it may look black, that is still blood. Sometimes you see clots. So these are things you have to be cognizant about. I always tell people, whenever you go to the bathroom and you have a bowel movement, before you flush, take one look. You know, if it's red, the water around is going to be red, and then you got to go call somebody. So always take a look. Don't be afraid of your stool. Take a look. The second thing is changing bowel habits. Changing bowel habits, I think I'll do some more explanation into that. Because changing bowel habits is actually more common. It's probably the most common signs and symptoms of colon cancer. But oftentimes it goes unnoticed. It's only in hindsight that people realize that, oh, that's what happened. So what's changing bowel habits? So if you're somebody who has one bowel movement a day, that's normal for you. And then all of a sudden, you're having 3 bowel movements a day. And it's not because you're having diarrhea because of something you ate. And this continues maybe for about a month, maybe for a couple of months. You should get a colonoscopy. The other side, if you're somebody who's having 1 bowel movement a day, and then all of a sudden, you're having a bowel movement every 3 days, and you're straining, and it's not because of some bread or pizza or something that you ate that is causing you to have constipation, and this goes on for a month or 2, that's a change in your bowel habits, and you should see a doctor and get referred for a colonoscopy. Narrow caliber stool, that is when sometimes if the cancer is grown and it's big, it kind of grows into the lumen of the colon, so your stool becomes narrow. It looks like a pencil when it's coming out. When you see that and it's happening all the time, please go talk to your doctor. Abdominal pain, that is not common with colon cancer. It's usually, it can happen, but that is sort of at a later stage. Unexplained weight loss, that's also a later stage symptom. But fatigue can be an early stage symptom and the fatigue is usually due to anemia. The cancers, even if you don't see blood in your stool, these cancers still tend to bleed. And so sometimes people show up and they've had the cancer for a while, and there's been this very slow, invisible bleeding. And so they show up tired because they are anemic. I know some people who are even so tired, they don't know what's going on with them, they become depressed. And later on to find out that they actually are anemic, you get a colonoscopy and you find out that they have colon cancer. So please keep these symptoms in mind. So how do you diagnose colon cancer? And it's mainly through colonoscopy. That is well and truly the only way to diagnose colon cancer, where you can actually see the cancer, take a biopsy of it. They'll look at that biopsy under the microscope, and then they'll confirm whether you really have cancer or not. We also do what we call staging for all cancers. So I'm sure if you know somebody who's ever had cancer, they always talk about stage 1, stage 2, stage 3, or stage 4. And the reason being that we stage cancers to help us to treat, because all cancers in stage 1 are treated a certain way, stage 2 differently, stage 3 differently, and stage 4 differently. And they all have different prognosis. So whenever you have cancer is diagnosed, we always stage them. And they do a CAT scan of your chest, abdomen, and pelvis, or an MRI, ultrasound. And you do all these things to try and figure out what stage your cancer is. And then the stage will eventually determine the treatments. The CEA is some kind of a lab marker that we use, a blood marker, I should say, that we use to monitor people who have colon cancer, and it will let us know if the cancer is coming back. Your CEA will go up. And when that happens, then they have to restage you and see if they can find where the cancer has recurred. So treatment for stage 1, 2, and 3 is usually surgery. If you have stage 3, after surgery, you get some chemotherapy as well. Stage 1 and stage 2, surgery is usually enough. So surgery can be curative. I know people always say, we still can't cure cancer. Why? But we can cure cancer if it's found early. So stage 1 and stage 2 colon cancers are virtually cured, especially the stage 1s, if you find them, if you treat them early and they get surgery. Stage 4 is incurable. It means the cancer has already spread. So how do you prevent colon cancer? And that is screening. The new recommendation is screening at age 45. And it used to be 50. Then it went to 45 somewhere along, I think around 2015. But everybody knows about 45 recently. And the only reason is that although the doctors, the different society, American Cancer Society, the Colorectal Society, the Gastroenterology Society, we all thought that screening should go down from 50 to 45. The insurance companies were not prepared to do that because they have to pay more. So until actually 2020, that certain states start forcing the insurance companies, they started passing laws to force them to start screening at 45. Now the insurance companies have decided that, okay, they don't want to fight the lawsuits, and so they have to go ahead and start screening at 45. So that's why it's now 45. So in the medicine world, it's been 45, and that has been the suggestion for over 8 years. But now it's 45, I think, almost everywhere. Almost all insurance companies are paying for 45. So get your colonoscopy at the age of 45. There are other tests that people sometimes try to use for screening, although they are not really very good at screening. There's something called the FIT test. The FIT test actually, it tests for blood in your stool. It's a cheap test, and it's a way to, I always think that that's something you can use in Ghana, because the FIT test may cost maybe $6. If you're doing an annual FIT test, it's not the best kind of screening, but colonoscopies in Ghana, for instance, can be quite expensive. So if you can do a FIT test every year as part of your annual physical, it may help you find your cancer just a little bit earlier. Cologuard is quite popular now. They advertise a lot. What Cologuard does is that it is Cologuard, it looks for blood in the stool and also the DNA of the polyps and the cancer. The DNA part is not as advanced as we all would like, but it's still the best we have. But I think it's going to get better with time. But Cologuard is not the best screening method, I should say. Colonoscopy is still number one. CT colonography is also another way that people try to screen, and it's a CAT scan, and it means it's sort of like an X-ray where they would have to blow air into your rectum to dilate the colon, and then they take the X-rays or they take the CAT scans, and that helps them to find the cancers. But it's not very specific, because sometimes a piece of stool that was left behind can look like a polyp. So then it really hasn't helped you. But with all these other tests, the FIT test, the Cologuard, the CT colonography, if they come back as positive, you still have to get a colonoscopy in order to get your diagnosis. So I always say, why don't you just go and get a colonoscopy? You know, I'll talk a little bit about colonoscopies now. Age 45, it's a pretty straightforward and very safe procedure. There are some risks that comes with it, like bleeding and perforation, but that is still less than 0.05%, you know, so about 4, it's usually around 4 per 1,000. That's where the risk tends to be. It may be a little bit higher depending on where you live and who your gastroenterologist is, but that risk is still usually less than 1%. The PrEP, that is what you take to give you diarrhea in order to clear your colon so that the person doing your endoscopy can actually see. It's very important that you follow the instructions very carefully, because if you show up for your colonoscopy and you still have stool in your colon, it means they cannot see very well and they could miss polyps or cancers, and you don't want that. So follow the instructions and make sure you get a good PrEP. You know your PrEP is correct when you start passing almost what looks transparent. It's like water. It may have a little yellowish tinge to it, but when you see that and a few particles, but you still know that at least you have a good PrEP. But if you're still seeing stool, it means your PrEP is not adequate. So you go in, you get a colonoscopy the same day to be done for you. If they find some polyps, they'll tell you then that they found polyps and took them out. If they find something else like a cancer, they'll biopsy it and they'll tell you, but they will not be able to confirm if it's cancer or not immediately. That may take a couple of days. If your colonoscopy is clean, they'll tell you to come back in 10 years. But if you have a few polyps, they'll tell you to come back depending on how many polyps and how advanced the polyps are. You may come back in a year or sometimes 3 years or maybe up to 5 years. Okay, so that's colon cancer. The next thing I'm going to talk about is diverticulitis. Diverticulitis is an infection of diverticulosis. So people say, what's diverticulosis? This is diverticulosis. Diverticulosis, this is a colonoscopy picture. These pockets here that you can see are what we call diverticulosis. And sometimes you can get stool get impacted in them, like here and here. And when that happens, it blocks off the pocket and it can perforate, and then you get diverticulitis. And diverticulitis, it's becoming more common. It's quite common here in the US, but it's becoming more and more common in places like Ghana. It is an elderly person's disease because I have a few patients that are in their 20s who had diverticulitis, but that is not common. So by the age of 40, only 5% of people have diverticulitis, but by the age of 85, 65% of the population will have diverticulosis, okay? And having diverticulosis does not mean you automatically get diverticulitis. We used to think that 25% of people who have diverticulosis will develop diverticulitis, but that's not true. Today, we know that that number is somewhere around 4 or 5%. People do get recurrent diverticulitis, which means that diverticulitis can come back. And that's not for everybody. Some people get one attack, they never get it again. But for other people, they can get it every year, a couple of times a year, and sometimes the frequency can increase. The cause is usually benign, it's treated with antibiotics. But in severe cases, sometimes you may need surgery. So I can't talk about diverticulitis without talking about history. And that is because, let me start off by saying that certain diseases or illnesses like hemorrhoids has been around forever. The ancient Egyptians actually wrote on papyrus about hemorrhoids. They wrote about anal cancers. They wrote about blood in people's urine, but diverticulitis was never found anywhere in history. Ancient Mesopotamia, they wrote about hemorrhoids as well. Diverticulitis showed up basically in the late 1700s, and it was after the invention of the wheat mill. And that is when we went from eating proper food to processed food. So the invention of the wheat mill is when we started processing our food. That's when people started making finer bread instead of the rough bread. And this was eventually confirmed by 2 British doctors in 1971, showing that actually we developed diverticulitis because we did not have enough fiber in our diets. So processed food, somehow the more we process our food, the more fiber we take out of it, and we end up with less fiber in foods, and this is what is causing diverticulitis. So low fiber in Western diets leads to their higher rates of diverticulitis. And this can be shown in Singapore and Australia, and South Africa, which are countries that used to be poor, had less diverticulitis, but as they became more developed nations, their incidence of diverticulitis actually increased. And it makes you wonder what's going to happen to Ghana. Growing up in Ghana, the most common food in Accra used to be kenke. Kenke and fish was common. It was cheap. You could buy, But today, I understand the most common food in Ghana is indomie, which is just noodles, and it's just starch and has nothing else. Zero fiber, zero protein, zero minerals, zero vitamins. It's just starch. So stay away from indomie unless you're eating it with some wachi. So will Ghana be having more diverticulitis in the future? And I think if you talk to the surgeons in Ghana, they'll tell you that they are actually already seeing an increased incidence of diverticulitis. So it's coming. The diagnosis is usually clinical, which means the patient will be having pain in their left lower abdomen, their white cell count will be elevated, or they'll be having a fever. And usually they do not have any nausea and vomiting. If they're having nausea and vomiting, you have to consider other diagnoses. And you can do a CAT scan to confirm your suspicions if you want. But usually your primary care will see you and they would treat you, from home. The treatment is usually bowel rest and antibiotics. So they'll say for the next 2 days, don't eat any food, but you can drink, of course, otherwise you get dehydrated, and then they'll give you some antibiotics. If your diverticulitis is severe, you have to go to the hospital, and then you may get admitted, and then you may get IV antibiotics. And if it's really bad and there is a perforation, that is where I come in. Then you need surgery. So the next topic is inflammatory bowel disease. This is one of those diseases that is also more common in the West, but it's becoming more and more common in other countries. In the 70s, this Crohn's disease and ulcerative colitis were considered Northern European diseases, which means that the British and the Scandinavian people and the Germans had these diseases, and the Italians and the Spanish did not have inflammatory bowel disease. But over the years, and definitely not Hispanics and definitely not Black people, but over the years, this has changed. We still don't know why. But it went from being Northern European disease to being now a European disease. And now it's everybody's disease if you live in America. There are lots of Black kids who have Crohn's disease, same with Hispanic kids, Indian kids. It's just everywhere right now. This is a disease that is actually increasing. It's still quite rare in places like Ghana. But I can tell you that there are Ghanaian kids who, when they move from Ghana to America, they develop Crohn's disease. Once again, it's an environmental thing, and we still don't know what may be causing it. I have some friends whose kids actually have Crohn's disease, and they're Ghanaian kids. So there are two diseases that are quite similar. Some people tend to see them as being on the same spectrum. Ulcerative colitis affects just the colon and nowhere else. And it affects a part of the colon, sometimes all of the colon. Crohn's disease affects certain parts of the colon, but the lesions are usually skipped. It means you have in between the sick part of the colon, there will be healthy parts as well. And Crohn's disease does not affect only the colon, it affects anywhere from your mouth to your anus. It can affect anywhere in your GI tract. So they are actually autoimmune diseases. They are sort of like arthritis that you have in your joints, but this is your body attacking itself. So it's attacking your colon or your bowel. Most of people have bloody diarrhea. There'll be some mucus. Abdominal pain is quite common. And it leads to people not being able to eat well, so they lose weight, bloating, gas, are also hallmarks of this disease. Diagnosis here, once again, is colonoscopy. You get a colonoscopy, and then they would find the lesion and take a biopsy of it. Then the pathologist will confirm the diagnosis. Flexible sigmoidoscopy is sort of like a colonoscopy, but you don't go all the way throughout the colon. This is just limited to just the rectum and the most distal parts of the colon. Upper endoscopy, you go through the mouth to look for lesions there, and you can biopsy them as well. A capsule endoscopy is not used very often, but it's sort of like a camera that you can swallow, and it takes pictures of the GI tract, and it can help to identify some of these lesions. But ultimately, they have to be biopsied to confirm the diagnosis. The treatments, there are certain NSAIDs. These medications are like aspirin. The most common one is called Pentasa, and has been around forever. And has been used. They are not as effective as we like, but if your disease is mild, that's the first choice. Some people do need antibiotics and sometimes even antiviral medications, but biologics have become the hallmark of treatment of these diseases. The biologic medications, I'm sure you all see them being advertised on TV. It's all these Stelara, Entyvio, Skyrizi. They are all medications that are used. Sometimes the same medication can be used to treat psoriasis, and you see them, they are advertising. They are new drugs, they are pretty good, and they are very, very expensive, but they are effective. Immunomodulators are older drugs. They've been around for a long time. They used to be the main treatment options for these diseases. However, they are kind of falling out of the way. Sometimes they do get combined with some of the biologics. Steroids can also be used, but steroids are used only as rescue, because if you're on steroids for a long time, the side effects may actually be too much, and the side effects may be worse than the disease itself. And after all the treatments, if all else fails and nothing helps, then you call me. Then I come in with surgery, and surgery usually can reset. You resect the sick part of the bowel, and it allows the patient to get back on the medication and get treatment. But if they fall off their medication again, they may come back and need surgery again. Yes, a few nasty pictures coming your way. This is anal condyloma. These are warts. They're usually caused by HPV virus, which is basically the same warts that can cause cervical cancer in women. It can cause these kind of warts and can also cause anal cancer. So the HPV virus is very common. It's sexually transmitted, or sometimes just by contact. If you've been sexually active for a year, then there's a 95% chance that you have the HPV, even if you've been active with only one person. So you can't really tell who gave it to you, and nobody knows. And the thing about HPV too is that it stays latent. You can catch it, maybe you caught it in 2010, and you grow your warts in 2025. So you can't really go back. You don't know when you caught it. The warts just show up. It doesn't mean that the person that you're active with right now gave it to you, because sometimes it creates that confusion. So HPV is not really something that you can trace, but you just have to know that it causes warts. And so if you have these warts, you have to have them treated. Otherwise, the warts can develop into anal cancer if they stay there long enough. It takes the warts probably about 10 years to become cancer, unless you have HIV. If you have HIV, then it takes about 5 years. So if you have warts, talk to your doctor and get it treated. They itch and they bleed, and you can always feel a lump there in your bottom. And the treatment is usually, if they are small, it's usually topical. There are different ointments they can give to you and creams that can help to treat them. So get it treated. But if they are larger and the ointments are not working, then they call me and I'll take them off for you. Next is anal cancer, also caused by the warts as well. So if you have warts and you don't treat them, they become cancerous. These tend to bleed, and they can also itch, and they cause a lot of pain. I'll talk about another disease that causes pain. That's a fissure. Or you can feel a lump and there's a lot of mucus discharge. And in worst case scenario, they can affect your sphincter muscle, so people become incontinent. The treatment is actually radiation with a little bit of chemo. And it's very effective in 90–95% of the time. And if in the 5% where it doesn't work, then you need surgery. And that's where I come in. Hemorrhoids. Hemorrhoids are everybody's, I always say that every country, in America, anytime anybody has any kind of problem around their anal area, they always say they have hemorrhoids. If you go to England, they always say they have piles. And in Ghana, they probably say they have cocoa. So there are many different things that can be referred as piles and hemorrhoids. And I'll say that if you look, the patient that I see in the office, I'll say about 25% of people who are on my list to see me with hemorrhoids don't have hemorrhoids. They have other things. Some it's cancer, some is a fissure, some is an abscess, some is just warts. But people just think of anything around the anal area and they just think of piles, hemorrhoids, or cocoa. So now if you have proper hemorrhoids or piles, this is what they can look like. This is a pretty bad one. For most people, it doesn't really look this bad. They're actually veins or sometimes arteries that are swelling around the anal area. They're usually caused by constipation is the most common cause. You can't get it if you have severe diarrhea, but it's usually because of pressure from constipation. So people who go to the gym a lot, sometimes weightlifters can get hemorrhoids. And it's definitely the hallmark of pregnancy because not so much during delivery, but more from the pressure in the abdomen from the baby itself. So hemorrhoids is quite common in pregnant women. And usually after the delivery, the hemorrhoids tends to go away. So hemorrhoids can both be internal and external. And 75% of the population has hemorrhoids. So I think there are about 30 people on here, which means 25%, 25 of you all have hemorrhoids. Make sure you get them treated. Otherwise, sometimes they can just get worse and they can bleed and cause you a lot of issues. But hemorrhoids are in general quite benign. There are many hemorrhoid creams and suppositories that can be used. But the best treatment for any of the over-the-counter things that you can buy at the pharmacy is actually fiber. If you have hemorrhoids and you don't want to see a doctor or you haven't seen a doctor, just get some Metamucil or some Benefibers. Eat more fiber in your diet. That would really help to improve your hemorrhoids. If that doesn't help, we can do something called rubber band ligation, where we actually put a rubber band around the hemorrhoids on the inside, and that will make them shrink. And if that doesn't work, then you come and see me for surgery. Surgery is not very, it's common relatively, but we do it for the worst case scenario. That is when there's nothing else helping and the hemorrhoids are big and they are causing you a lot of issues, then we can consider surgery. The other thing I'm going to talk about is fissures, because fissures are quite common, but most people usually show up thinking that they have hemorrhoids. Hemorrhoids usually don't cause a lot of pain unless you have a clot in them, unless they get thrombosed. But fissures, that's a tear inside the anal canal, and that is painful. Fissures are usually really very, very painful for people who have them. And it's a tear in the lining. Sometimes it bleeds, sometimes it doesn't. And it's usually caused by constipation. And the pain is severe. The pain is severe, and then you have a bowel movement, and you think that, you're gonna, God is gonna come get you because the pain is really, really bad. And for a lot of people, I'll say that if I see a patient in the office and they tell me that I am having pain with bowel movement, and 2 hours later, the pain is even worse and I'm having spasms. And so, doc, I'm even afraid of going to have a bowel movement because of this pain that I know is coming. If I hear this story, you don't even have to examine the patient, you know it's a fissure. And luckily, you don't always need surgery to treat the fissures. There are usually two kinds of creams. One is a nitroglycerin ointment or nifedipine ointment. These are usually made in compounding pharmacies in America. In many other countries outside America, you can actually buy them over the counter in the pharmacy. But here, you can't even buy them in CVS. They actually have to be made in a compounding pharmacy. Why? I do not know, but I think it has to do with capitalism. But yes, so they make them in the compounding pharmacy and they're very expensive. Like the nitroglycerin made in a compounding pharmacy is sometimes up to $60. Whilst if you buy it over the counter in Mexico, it's probably 75 cents. Anyway, so you have to use the ointment 2 or 3 times a day for up to 6 weeks. If you're still having pain and it doesn't go away, then you have to see a surgeon. And there are 2 ways to treat it. Usually we inject Botox to relax the sphincter muscles, or sometimes we actually make a cut in the sphincter muscle to release the spasms. And that helps the fissure to heal. Perianal abscess, that's sort of what we call a boil. It's a boil around the anal area. And if you lance that, it's usually filled with pus. Nobody knows why some people get it. Some people do, some people don't. But if you have it, seek treatment. It causes pain. And usually if they rupture, they start draining by themselves. The best way to treat it is actually to have it go to the emergency room. They can lance it for you and drain the pus out and put you on some antibiotics, and that would help it to heal. Okay. Sometimes if the abscess keeps coming back at the same spot, then people have developed something we call the fistula, which means that there's a connection between the abscess and inside the rectum. That you have to see a surgeon to fix. But not every abscess develops a fistula. So usually abscesses are drained, and then that's the end of the story. The last thing I'm going to talk about is what we call your gut microbiome. This is an area of colorectal surgery that is growing. We are all learning more and trying to understand what is going on with our gut. Your microbiome is basically the organisms that live on the lining on the inside of your colon. They create sort of like a microsystem, which when disrupted can make people ill, and we know that. But we don't know exactly what, we know certain diseases, but not all of them. We feel like there's more that needs to be studied here. We know that when you take certain antibiotics, it disrupts your microbiome, and that is why sometimes people get diarrhea. And you can get the overgrowth of certain bacteria that can cause abdominal pain and gases. And we know too that this microbiome can affect people's mood and behavior. And very importantly, it can also help to fight, it can be part of your immune system and help to fight certain diseases. So your microbiome and your colon does quite a lot of things. Most people think that the bacteria is just in your colon and that's what makes your poop smell, but the bacteria actually has many other purposes. If you look here, it promotes the storage of fats. It promotes something called short chain fatty acids, which we need in our metabolism. It helps you regulate the nervous system. It's part of your immune system. There's a very robust immune mechanism going on in your colon. It helps you synthesize certain vitamins, usually B12 and K. And it also helps to fight against some of the pathogens that could that of some of the things that we ingest. It helps to fight against that. Okay, so it's a new part of colorectal that's there's still a lot of studies being conducted, and so I just want us to kind of know about it. It's always good to improve your microbiome, and you say, how do you do that? And by taking probiotics, which are usually fermented foods and then live culture bacteria, usually in yogurts. Sometimes you can find them in pill form. So probiotics they're good for you. They also what we call prebiotics, and here again we have fiber. So make sure more fruits and vegetables, grains, oatmeal, rye, and things like that, which have a lot of fiber in them, that all help to improve your gut microbiome. So since I'm a surgeon and I'm talking about surgery, I just want to just a little information about modern colon and rectal surgery. So we used to do surgeries like this, and we still do that sometimes, where they make a big incision and we can see this is the colon and this is part of the small bowel, and this is how we do surgery. This is how we've done surgery for centuries until about, I'd say 30 years ago, when we started doing surgeries a little bit differently. Laparoscopic surgery, where we actually use a camera. So this is a camera, and we use these ports and we put certain instruments through the port, and that helps us to manipulate the organs in the abdomen. And that's how we do the surgery. This is what it can look like. This is the camera inside the abdomen whilst you're doing the surgery. And usually, as you can tell, the patient doesn't have the big cut, but has only small, tiny incisions. Laparoscopic surgery leads to faster recovery for the patients, but more importantly, with fewer complications. The big cuts that we used to give patients, and we still do sometimes if we can't do the surgery laparoscopic, it usually leads to a big inflammatory reaction. And sometimes that is almost as bad as the disease that we are trying to treat, because that really makes people sick. And then they can get hernias, they can get infections in these big cuts. But in these small incisions, you hardly ever get hernias and they hardly ever get infected. So your complication rate with laparoscopic surgery is much lower. And the next step now, in the last 10 years, we've moved on to robotic surgery, which is like laparoscopic surgery, but it's a little more advanced. The camera is better, it's a 3D camera, and the surgeon actually gets to sit in a console and control these robotic arms to do the surgery. This is what it can look like. The surgeon sits behind a console, and the patient will be here, and they have these instruments going inside the patient, and the surgeon will use this console, and we have these controls that we use to control the instruments on the inside of the patient, and we are able to do the surgery that way. The camera is incredible. It can zoom everything 10 times, which makes you feel like you're right into in the person's abdomen doing the surgery. And very impressively, it's also a 3D camera, so you really get to see very well. If you are doing open surgery, the patient is open and you are standing, and so there's about 2 feet from your eyes to the patient, and then also the depth of the patient. So you're actually looking about 2.5 feet away when you're doing that kind of surgery. Whilst with the robotic surgery, you actually can zoom everything in, and it to be as if it's right in your face. So you can see much more details, and so we believe that it is actually safer. So there's no robotic surgery going on in Ghana yet, but maybe one day. The robot costs about $1.5 million. But there is some laparoscopic surgery going on in Ghana, and one of my, we have set up a laparoscopic surgery unit in Ghana, and I hope that I can have the opportunity to be able to train more Ghanaian doctors and surgeons in laparoscopy, because patients just recover so much better. So the two main takeaways from this talk is fiber. One, fiber. So you need fiber. Fiber will help prevent your diverticulitis. Fiber will help prevent your hemorrhoids. Fiber is good for your gut microbiome to make you feel better. So please, you need about 25 to 35 grams of fiber a day. If you don't have enough of that in your diet, always take a fiber supplement, like Metamucil, Benefiber, any of those things. The only ones I don't like when it comes to that is they have these gels, or these jello fiber gels, they call them, and some of them just don't have enough of the fiber in them. But if you do the Metamucil, they usually contain enough to help you get to your 30 grams a day. The second thing is colon cancer screening is at age 45. So if you are 45 years old and you're on here and you haven't had your colonoscopy, please do. It will save your life. Thank you. This is the flyer for the free surgeries that I was talking about in Ghana. I'll give this to Dr. Jacobs-Abe. You can put it somewhere people can access it. It's if you know somebody who need any of these services. We also are going to treat some chronic wounds. Please let them contact us, and hopefully when we go down in April, we'll be able to help them out. Thank you. So any questions?
All right, thank you very much, Dr. Nunoo. So like he said, the floor is now open for questions. Please feel free and just chime in, just unmute yourself. And then if you can't, or you feel like we're not hearing you, just send a text or something on the side, and we'll make sure that your questions come up and he addresses them. So please, the floor is open if you have any questions.
Yes. I see a raised hand somewhere.
Yes.
Yeah, please go ahead.
Do probiotics really work?
The probiotics do, actually. So there are certain instances where I tell my patient to take probiotics, and that is if they are on long-term antibiotics. And that's because the antibiotics tend to kill some of the good bacteria that you need in your gut. And so then patients end up getting diarrhea. But if you can do that, if you can take some live culture, some yogurt, it usually helps. So probiotics do not help to prevent cancer, no, but it helps to improve your gut biome, so it makes you regular, stuff like that. But no, it's not going to cure or prevent you from getting cancer, no.
Thank you.
You're welcome.
So doctor, I have a question. Now, from your presentation, I realized that the one ought to pay attention to the back. So what about this? How does this affect those who practicing gaze and stuff like that? Because the anal becomes the entry point for them. And so how does that affect them, and how does that impact our society?
Good. It doesn't really impact our society, but sometimes, there are certain, I would even say people who are, if you are, gay and practicing anal receptive intercourse, there are many non-gay people who practice anal receptive intercourse. The fissure that I was talking about, people get fissures, and it's usually from constipation, but sometimes it can be from anal receptive intercourse. And you see the women who have that, there are men who do that and still don't consider themselves as gay. But it doesn't, being gay doesn't really put you at risk or any higher risk for any of these things. But what will put people at risk is if you are HIV positive. People who are HIV positive, which still in the US, it's quite common amongst some of our gay friends, is usually because it can lead to them sometimes it's easier to get infections. So they can get more abscesses and fistulas. But the anal cancer part, the HPV, if you are HIV positive, the HPV virus tends to grow a lot faster. So the transformation from the wart to cancer is usually 10 years in everybody else. But if you're HIV positive, then it's a lot faster, and it's usually 5 years. So my patients who have HPV and are gay, I tend to monitor them much more closely. So instead of maybe seeing them once a year, once every other year, sometimes you have to see them every 6 months.
Gotcha. Thank you.
You're welcome.
All right, Dr. Nunoo, I also have a question.
Yes.
So when it comes to constipation, is it something that, like as we get older, does it become more prevalent? Is it something that we should be concerned about if all of a sudden our, frequency and things like that starts to change?
Yes. So I always say that, first and foremost, let's talk about what is constipation. Because constipation differs from person to person. There are some people who go every day. So if they don't go in 2 days, they are constipated. But there are some people who go twice a week. So if they haven't gone in 2 days, that is not constipation for them. So what I always ask is that, are you straining where do you go? If you have to sit there and you have to strain, you have to push, then you are constipated. And yes, sometimes as we tend to become old, when we become older, but more into, I'll say, your 70s and 80s, you can develop some element of constipation. But usually the most common cause of constipation is something in your diet. That's what you have to look at first. Bread, white bread, without the fiber, without the roughage, is usually the most common culprit. And that means that pizza is a very common cause of constipation, because cheese can constipate you as well, together with the white bread. So pizza is a big constipator. So it's usually a diet thing. If you don't drink enough water, if you don't exercise, these kind of things can lead to your guts not being very active and can cause constipation. So I always tell people, make sure you drink enough, at least 8 glasses of water a day, especially during summer when it's really hot and we all sweat a lot and you lose a lot of moisture through evaporation. Make sure you drink. If you do, if you don't, then constipation can set in. And exercise is another thing. Anytime you do some exercise, the adrenaline that you get, that can is good to counter constipation. That actually stimulates your gut as well. So exercise, drink enough water, make sure you have more fiber in your diet, then you can avoid constipation.
Awesome. I think Kabna Sari has a question.
Yes.
Yes.
Dr. Nunoo, when you go to Ghana to perform procedures, we know that one of the, it's very important that somebody follows this patient up after some of these major surgeries. How do your patients follow up when you return to the US?
Yes, so we are going to Ghana for the first time to do this in April. But we do have some surgeons that are local in Ghana who will be following these patients. We have, there are other doctors in that facility, and they will be the first point of contact. But if these patients need further follow-up, then there are other surgeons that would do that. My plan actually is to, when we go now in April, we're staying for 2 weeks. And then I do have another lady who's going to come. So we're leaving on the 5th of May to come back to the US. And I'm planning for a lady who's going to go from here, and he'll be in Ghana on the 20th. And she'll be staying also for 2 weeks. And so she'll be seeing some of these patients as well. And she would also be doing some of the surgeries. Ultimately, what we want to do, and it's not just me, there is a fantastic young Ghanaian lady, her name is 𝙅𝙬𝙗𝙤𝙗𝙤𝙗, who has really helped to set up colorectal surgery curriculum for the surgeons to be trained at Kolebu. And we gave them a bunch of lectures all through January, 3 weekends in a row, 5 hours every Saturday. We gave them some lectures just to help to train these young people. And I'm hoping that some of these trainees, some of these residents in Kolebu will actually come to Pleasant Medical Center with us to learn the laparoscopic skills and take it back to Kolebu or wherever they want to. But, one day, I would say that if the day when I've trained 10 Ghanaian surgeons to do laparoscopy, I think I'll be very pleased with myself.
Thank you.
Thank you.
I think Dr. Abidwan's hand is up.
Yeah, thank you, Dr. Abe. Dr. Nunoo, if I may, and you might have addressed this in your presentation, so excuse me or forgive me. With regards to colonoscopy, I know it's at age 45 now.
Yeah.
Now, how often is it recommended, or does it depend on what they find at your first?
So one, I always say that if you have family history, let's say if you have a first-degree relative, that is your mother or your father or your sibling has colon cancer, you should never go more than 5 years. If anybody tells you go more than 5 years, find another doctor to do your colonoscopy. On average, however, if you get a colonoscopy and they don't find any polyps, they will usually tell you, that's the person of average risk. They will usually tell you to come back in 10 years. If they find some polyps, it depends on how advanced the polyps are, because the polyps, they go through different stages before they become cancerous. They're usually 4 different stages before they become cancer. And so if they are advanced, they'll bring you back sooner, maybe in a year. If they are less advanced in the early stage, maybe they'll tell you to come back in 3 years or 5 years. So it just depends on, one, how many polyps you have and the stage of those polyps.
Great. There's another question in the chat. I think it's coming from Abi, and he said, "How does one manage diverticulitis without surgery?" And the follow-up question is, how do probiotics and probiotics have to be taken together for better results, or is it one or the other?
I'll say yes, take both your pre and probiotics. Prebiotics basically just means fiber. Make sure you have enough fiber in your diet. It's one of the takeaways from this talk. Fiber, fiber, fiber. Fiber is good for your colon health. So, some Metamucil or fiber, psyllium husk, make sure you have enough fruits and vegetables. Fiber is always good. So diverticulitis treatment, that just depends. If it's mild diverticulitis, it's treated with antibiotics and bowel rest. You don't have to, your primary care doctor can treat that. However, if it is more severe, then you have to go to the emergency room, and sometimes they'll get a CAT scan and they may end up admitting you. And in certain cases, if it's really bad and there's a perforation, then you end up having emergency surgery. But most diverticulitis patients are treated just with antibiotics and bowel rest, and they never have to see a surgeon.
Great. There's another question. I think this is from Planet. It said, Dr. Nunoo, what about those who are not 45 years yet, yet still talk to your doctor and request a screening?
So I'll say no. You don't have to. If you're 45 years, if you're having symptoms, the symptoms that I talk about, if you have some bleeding from you see blood in your stool, I always say, when you go and you have that bowel movement, before you flash, take a peek, one quick glance, make sure there's no blood, and then just move on with your life. So just make that a habit, because you learn many things about yourself doing that. So, sorry, I just lost my train of thought. What did you say? Oh, yes. If you are not 45 years old, yes. So if you are younger than 45, then it depends on symptoms. If you're having rectal bleeding, you should talk to your doctor. They'll send you for a colonoscopy. And if you're having what I said, I call that change in bowel habits, which means that, because that is usually even more common than bleeding when it comes to colon cancers. Change in bowel habits means that, let's say if you're somebody who is having one bowel movement a day, that's normal for you. And you notice that all of a sudden you are going 3 times a day, and you can't explain that with your diet, and that goes on for about a month, 2 months. That's a change in your bowel habits. Make sure you talk to your doctor and get a colonoscopy. If you are another person, you go once a day, and all of a sudden you're going every other day, every 3rd day, and you are more constipated, and that goes on for a while, and you cannot explain it with your diet, then also make sure you get a colonoscopy. So those are sort of the main things. So if you are symptomatic, yes. My youngest colon cancer patient is 24 years old. He was diagnosed at age 24, and he was pretty advanced. And he would tell you that the first time he had bleeding, he was 19. He was an illegal immigrant, so he didn't go to seek help. And when he came, it was quite advanced, but he was only 24 years old. And I believe that he probably had his cancer symptoms starting at 19. That is not common. That is quite rare. I have a couple more 20, 28, 29-year-olds. I have quite a lot of 30-year-olds, from 32 to 38, quite a lot of patients. So yes, you can still develop colon cancer at a younger age. And that is part of why the screening age was moved from 50 down to 40, trying to capture to 45, trying to capture more people, because colon cancer in all of America, the incidence is going down because more people are screening. However, in people who are not in the screening age yet, the incidence is going up. Not by a lot, but there is a slight increase, yes.
All right. I think Senior Kojo has a question for you. Senior Kojo, we can't hear you though.
Is he muted, maybe?
No, it's unmuted. It's unmuted, but we don't. It probably has an audio problem from his end.
Perhaps he can type the question in the chat and you can read it.
Yes. Yes. So while he does that, Dr. Meno has a question.
Dr. Nunoo, thank you for a wonderful presentation. I just want us to take us back to Ghana, some certain culture. Oh, sorry, my son, sorry. Kwefu, go to mommy, go to mommy. Oh, jeez. So, Abby, please let somebody ask. Okay, he's gone now. So, Jesus. So Dr. Nunoo, so a little taking us all back in time, from your, I missed the very beginning of the presentation. So I would like to assume that you probably grew up in Ghana, raised in Ghana a little bit, so you're used to the cultural practices.
Yes.
And if we all remember, as kids, they used to, I don't know what's the word, they say bentua, like as kids, they used to give us enema. Sometimes we have most of the common rate was probably constipation, but sometimes whether constipation or not, you get it. And then as people get older too, when I talk to my older aunties and uncles, regularly they'll just go get an enema, use herbal stuff. So and I would like to think you probably thought about it. And since you'll be going to Ghana in a few months' time, what are your thoughts about our cultural practice of giving this enema, especially for the older people and stuff? What do you think is in these herbal stuff? Could it be, quote unquote, their probiotics?
So the most important thing is about enemas is what's in them, because you can give somebody here in the US, we actually do something called soap sod enemas, which is actually just soap water. And if you give it to somebody who is constipated, it will make them go. So it's actually just increasing the volume of the rectum, and that stimulates people to have a bowel movement. So, but it also depends on what's in the enema, because the lining of the rectum can be, it's very absorbent, in that sometimes there are many medications. You can take Tylenol through your rectum and your body's going to absorb it. There are many medications that we give them as suppositories, and some even medications that we give as enemas, because the body is going to absorb it. So it depends on what's in the enema, whether it's absorbent or not. But I know that people do it, I think, usually mainly for constipation. And somehow in Ghana too, I don't know, they put some pepper in it. I don't know if the pepper it makes it burn a little bit, and it makes you feel like you are getting some medicine, But yes, the people do that. So actually, I don't know the ingredients. I know sometimes people use even a neem tree, they boil it and they use the water to do enemas. So yes, it definitely helps for constipation. But for other things, it just depends on the ingredients that's in the actual content of the enema.
Thank you.
Thank you. I mean, I think as I'm going to Ghana more often and I start practicing more in Ghana, I expect to learn a lot, So I'll hopefully find out more about some of these things, yes.
So it looks like we have 2 questions in the chat. Propro, you going to read them?
Yes, let me see. Okay, so one is from Robert Opan. Opan, I'm sorry about that. It said, Dr. Nunoo, when you see rectal bleeding, is it always associated with colon cancer, or other forms of cancer can also result in rectal bleeding?
So when you see rectal bleeding, the most common cause of rectal bleeding is hemorrhoids, because hemorrhoids tend to bleed. And like I told you, hemorrhoids are usually painless. They can be painful if they are thrombosed, if you have a clot in them. So hemorrhoids are common and they tend to bleed. So I always tell people, but you still don't want to be that person who goes around thinking you have hemorrhoids. I've had patients come to me for 2-3 years, they thought they had hemorrhoids, and they show up and it's rectal cancer or anal cancer. So if you're bleeding, still let somebody have a look, let somebody take a look. It's very important. But yes, anal cancer can cause bleeding, fissures can bleed. Sometimes if you have a small bowel cancer, that can also cause some bleeding, but usually you don't see that, you don't see the red blood in your stool like that. Sometimes the blood can be black. So when your stool is black and you're not taking iron tablets, that could be blood. So sometimes the stool is black and it could be bleeding. So just be cognizant about that as well. So yes, there are many different things that can cause rectal bleeding, not just colon cancer. But colon cancer, anal cancer is the most dangerous. So you always have to make sure that those are excluded.
Awesome, thank you. Yeah, and this is from Senator Kojokran. So he said, for 5 years, my wife had a fit test done similar to colon GERD, yet they did not detect her colon cancer. Why are these tests still being used? Why aren't doctors just proceeding with colonoscopies?
Yes. So I always tell people, if you're in the US, I say just get a colonoscopy. But sometimes people are afraid of colonoscopies. They are afraid of the procedures. That's why Cologuard is quite popular, because people think it will prevent them from getting colonoscopies. But usually, fit tests, for instance, are about 96%, what we call, they have a 96% negative predictive value, which means that 96% of the time, if they tell you that you don't have, there's no blood in your stool, it is correct. But there's 4% that it may be wrong, So nothing is 100%. And even colonoscopies can miss polyps because you're relying on human beings to actually see. And our eyes are good, but sometimes they are not perfect. And so usually when they are doing colonoscopy, everybody in the room looks at the screen, not just the person doing it. There are usually 2 nurses, one assisting and one recording, and everybody just looks on the screen with the surgeon, trying to look just so that we don't miss things. And we know polyps get missed because it's been studied. The way they studied them was they had one person do the colonoscopy, and before the patient woke up, another person came and did the colonoscopy again. And in 3% of the time, they found polyps. Nothing big, no cancers, but smaller polyps, were found, which means that they can still miss. So unfortunately, many things in medicine is not 100%. In places like Ghana, where the colonoscopy is really not, it's very expensive for most people. I think that a fit test with its 96% negative predictive value can serve a purpose, which means that you can do the fit test, and then if the fit test is positive, then you should go get a colonoscopy. That is just because of cost, but otherwise, I always tell people, just go get a colonoscopy. Some people tend to think that, oh, you say I should get a colonoscopy because you are going to make money. But the truth is that no. Usually colonoscopy is done by GI doctors and not by surgeons. I do them as well, but it's a very small part of my practice. But yes, colonoscopies are actually better than Cologuard, better than the fit test, better than the CT colonography. Yeah.
Awesome. I'm not sure we have any other question. Any other question? Any other contribution?
I'd like to ask a question, if I have your permission.
Yes. Please,
yeah.
Go ahead.
Thank you very much, Propo. Senior Robbie.
Yes.
Jeffrey Boham here. Thank you so much for everything you've shared with us. I can obviously tell that a lot of us have taken so much away. The challenge that I am facing right now is we have to be agents of change. We have to really think about how we translate that messaging back home to our people in Ghana. And I've had my own medical challenges lately. And some of the things that I've experienced is that when we tell people certain things we've learned medically, okay, what you find out is that people push back. They'll say, oh, our forefathers did it this way, they did it that way, X, Y, Z. So along the lines of what Dr. Menu just shared, we have to really look at the cultural context. So I want to know from you,
Yes.
Since you've had experiences in Ghana, okay, are there certain ways that we have to present that information, okay, about getting a colonoscopy and things like that? Are there certain specific ways, and are there certain kinds of food that we have to avoid? Certain popular foods in Ghana that we have to avoid if we're sharing this information with our people at home. I, for one thing I know is anytime that I eat chocolate, you know, I get constipated, but that's me specifically.
Yes.
So are there specific foods, local foods in Ghana, and are there specific ways that we have to really share this information, you know, pass on this information to our folks back home?
Back home, yes. So I always, you know, I think one of the biggest issues in Ghana in healthcare is information, okay? And it's I'll say two or maybe even threefold. One, the government does not allow, let's say me, a medical doctor, I can't really advertise and go and put out some information telling that this is better than that, this is better than that. But the shaman or the guy selling the cocoa medicine and the guy, they are allowed to advertise without any kind of control. So they own the waves. They share, they tell all these people all these stories, and they repeat it so many times, people tend to believe them. You know, so sometimes without evidence, and people come up with things. Yes, they are traditional, certain traditional medicines that have been effective, but there are also so many charlatans who are selling things on the buses and doing things like that. And that is really who we compete against, because one of the biggest problems is that people go and see these people for diseases like breast cancer. They go see somebody, you rub the breast with all kinds of things, it doesn't get better. By the time they show up in the hospital, the whole breast is eaten up and it's got maggots in it. You know, so the information is important. And I think that the government has to allow people, because the government is not capable of doing it, to actually start actively sharing this information so that we can take back some of what they are good traditional medicine, don't get me wrong at all, but there are also so many charlatans who are just making money off people. And either we regulate that, they should go to school and get certificates, we have to do something about it. Otherwise, it's going to be tough. The other thing about information is doctors giving, that is us doctors giving information to our patients. People go to the hospital and they come back and sometimes they don't even know what was done to them. I have an uncle who is very well educated. He's a chartered accountant and everything. He had surgery, and up to today, we don't know what they took out of him. We don't really know what happened to him. You know, so that kind of information just to I don't know why the Ghanaian doctors are also not sharing that information. I had a very harrowing story, you know, which I'm going to tell about a lady who lives in England and went to Ghana and was having abdominal pain. Then he went to a private hospital. She thought she had appendicitis. And she went there, she saw the doctor, and they weren't sure, and the whole thing got delayed. Eventually, 3 days later, she was so sick, they had to operate on her, and they did. And it turned out that she had appendicitis that had perforated. But they treated her, and she recovered. You know, so when she was going back to the UK, she actually went back to the hospital to see the doctor for a review. And she told the doctor that, oh, she would like to have her medical records so she can take it with her to the UK. The doctor said no. and I'm just like, but the records are actually hers. Here in America, you own your records. You can demand your records anytime. But in Ghana, unfortunately, this doctor was like, oh, you people, you don't respect. I've saved your life. You want what paperwork, you know? And then I'm like, but it is not for you. It's not about you. It's about the patient wanting to take the information to her GP back in London. So I think that is some of the things that we also need to address. It's tough because the traditional medicine sometimes runs deep, and the charlatans get to advertise a lot, you know. In fact, almost every day, if you're on the trotro or on the bus going to Adisado College, there's always somebody going to get up and give you this one medication that can cure 20 different things. You know, so as soon as something is curing more than 4 things, it's hard for me to believe that it works. You know, so yes, I think what I am doing at the Pleasant Medical Center, we have everything is electronic. Okay, it's all our information is on it's computerized. The only time you get a piece of paper is at the time of discharge, because you have to get a working diagnosis or a definitive diagnosis and then instructions. So you get one sheet of paper that should contain that, so that you don't leave our facility without you having an idea of what we are treating you for and you going home with instructions. So I hope, you know, that as there are more private institutions coming in, these things will become more and more commonplace, and it may force the government institutions to follow suit.
Yeah. So just a quick follow-up. You know, the thing is, I'm trying to get a sense of, before they even get to the hospital, okay, before they even come to the hospital, are there certain changes they need to make in their diets? Because you've talked about the fact that people need to eat more fruits and things like that. But you find out that when we go home, every time the first person tells you, let's go to the choba, let's go eat XYZ.
Yeah.
So from I would say a messaging point of view, what's the best approach to reach people at home?
Yeah. So as part of the talk, I did mention something about fiber and Indomie. So when I was growing up in Ghana, you know, Accra, the #1 food in Accra really was kenke, which has some fiber in the corn. And it's also fermented, which gives you some prebiotics. But today, the most common food, according to some of the doctors in Ghana, is Indomie. And it's cheap. And Indomie is just starch. It has no fiber. It has no vitamins. It has no minerals. It has nothing. It's just starch. And so as, you know, has happened in countries like Singapore and South Africa, as we develop and we are in our diet become more westernized, I think that we may start getting more of some of these diseases. And so we do, I don't know if I can say we do have to stop. It's kind of hard to stop, but we should hopefully modify some of these diets so that you can still have your fiber. You know, I think that yam truly has a little more fiber than potatoes. So your yam fries is better than your French fries, you know? And so there are still certain things that we're doing that is still okay, but make sure that we do more fiber. Beans has a lot of fiber. Beans is pretty good for fiber. So, and because we don't usually eat like salads like that, but a lot of the, you know, contumely, of course, has, you know, a lot of fiber in it, you know, so we do have, there are certain things in our diets, if we keep them, you know, we'll be better off. But as you know, if you go to Ghana, you go out with the family, whilst I want to eat some red or some banku and something, they want pizza. You know?
Yeah, just to share this with everyone, I mean, there's so many things that I have observed, because I set up a small business at home and there were certain things that I
Okay.
started looking at.
I'm in a meeting when I
Can you
finish,
believe
okay?
that the Indomie here has just about 1/10 of the monosodium versus the Indomie that's sold in Ghana?
Yeah.
Okay, and that one is so cheap that people say, why is the American one so expensive? And then I looked at it and I realized that the one sold in Ghana
Yeah.
has about 3,800 milligrams or something, mg
Yeah.
of monosodium versus 380 from the United States.
United States.
So those slight and mild things are things we really need to pay attention to. You know, so these are things that I think those of us on this side of town need to really share with people at home.
Yeah, and I think those are the things. I think the monosodium, the glutamate thing that's in soy, I think those things can be quite addictive, and that's why they put them in there.
Yeah.
And I think a lot of Ghana's Indomie actually comes from Nigeria.
That's it. That's it. I know that.
Okay, so one more question that I wanted to Dr. Nunoo, there's a question that's been that was typed that I wanted to read out. It's from Dr. Adolfo. He says he's in I think he's visiting Ghana and missed some part of your presentation, but his question mainly is about ulcers.
Yes.
And seems like many Ghanaians are told they have ulcers and run around wondering which foods to avoid. So he wanted to know if you could shed some light on it and how it relates to like bloating and things like that.
Yeah. So when it comes to ulcers, so we're talking about colon health, it's a little bit off there. But one thing that I would say about ulcers is if you're in Ghana and you are diagnosed with an ulcer, okay, 90% of ulcers should heal if you are taking your omeprazole once or twice a day for 30 days, okay? If after 30 days, you are still having symptoms, then you have to go back to a doctor and make sure they do a scope through your mouth to see if you really have an ulcer. Because usually ulcers, I think, gets misdiagnosed. Very commonly, it is conflated with gallbladder disease. So when you eat and you get pain afterwards, that's almost always is gallbladder disease and not ulcer. And so if you're having that, you're eating and you're getting pain, and people have that, they tell them it's their ulcer for a very long time. I think that it is very, very often gallbladder disease. So because omeprazole today or Nexium, they are very, very good drugs, or Protonics. If you take that for 30 days and you are still symptomatic afterwards, it is not an ulcer. It's got to be something else. Or if it's an ulcer, maybe there's a bacteria component to it. So that can be seen if they do the scope. So sometimes the way I tell, the people in my hospital, if you think somebody has an ulcer, because sometimes the ulcer can have a bacteria component, we call it H. pylori. It's treated with 2 kinds of antibiotics. So you give them the 2 kinds of antibiotics together with the omeprazole. That is the Prilosec, right? And yes, the antibiotics goes on for both 2 kinds of antibiotics goes on for 2 weeks, but the omeprazole goes on for 30 days. If after those 30 days, this person comes back and is still symptomatic, I can tell you 99% of the time that is not an ulcer, and that is probably the gallbladder or maybe the pancreas. It is something else. So then you have to try and get a scope. So, they should go and really look and see if it's an ulcer, but it's usually gallstones. When I was in Sweden, I did medical school in Sweden. There was a young man who came from Ghana to come and do his master's. When you look at him, he was so thin, very, very thin guy. And he was always complaining of ulcer. Always ulcer. And we're all like, dude, what's wrong with you? And one day the ulcer got so bad he went to the hospital in Sweden. When he went there, they told him that, no, it's not your ulcer, it's actually your gallbladder. And he was like, no, I've had this ulcer since I was in secondary school. And this has, I've had it for over 5 years. Anyway, so in the end, they told me it was his gallbladder. They took out his gallbladder. And I can tell you that within 3 months, this man gained like 20 pounds, okay? Because before he couldn't eat because anytime he ate, he was having the pain. And that is a hallmark for gallbladder disease. So he always tells me that, oh, you're very lucky you didn't train in Ghana. Otherwise, but I don't think it's just a Ghana thing. I think that very often, because here we can diagnose gallbladder surgery easily because they do laparoscopic surgery and it's very easy to do. In Ghana, if you have gallbladder disease, sometimes it's open surgery, which is a really big deal. So they try to avoid that, So when it comes to ulcer, I always think that there is some overlap with gallbladder disease, especially, in the way it's treated in Ghana.
Okay, so I'll take one last question, and then I'll let you share your final thoughts, and we'll wrap up.
No, let me say, tell Dr. Adolfo that if he's still in Ghana, I'll be coming to Ghana at the end of the month, on the 27th. If he's still there, he should come and see me about that also.
Okay. All right. Thank you. So I'll read the last question. Says this is from Hopsa 96, North America. What are your thoughts on flaxseed and chai in foods for gut health? Also, what are some foods from our Ghanaian dietary list to be really good for our gut health?
So flaxseed is excellent. That's your fiber. And I'm a big advocate for fiber. When it comes to Ghanaian dishes, usually a lot of our fiber comes from beans. So I think beans is probably our best source since, of course, the more salads you can eat, that is real fiber too. And then your fruits and vegetables, oranges, definitely more than mango and a lot of the other stuff, but definitely oranges will give you some fiber. But when it comes to food, I think beans is usually our best source.
All right, thanks a lot.
Okay.
So I think we'll wrap up. It's almost 10 o'clock now.
Yeah.
We started at 8 and it's been almost 2 hours, but you know what? It's worth it. And it's been an awesome presentation. I believe that everybody has taken one or two things from it. I don't want to take the words out of the good doctor's mouth, but if there are two things that we should take away from this presentation, colonoscopy, colonoscopy, colonoscopy.
Yeah.
Fiber, fiber, fiber.
Exactly.
I think if there are two things that we want to take away from it. So, Dr. Nunoo, I'll let you give your final thoughts and then we'll go. But before that, I just want to take this opportunity to thank you. I know you feel like you're one of us, so this is not a big deal, but it is. People pay good money and still don't get this kind of quality or this kind of intimate presentation. And this is a matter of life and death. There's no two ways about it. I remember when I talked to you when we were setting this up, one thing that you told me about that, there are some of the patients that you talk to or, played around with these things. And by the time they realized, it had actually become a death sentence, so to speak. So this is a big deal. Just because we don't see it a lot, doesn't mean it doesn't exist. This is, people's real life that they live. So we really appreciate your time and for taking the time to, open our eyes to some of these things. Before we, I let Dr. Nunoo close, I'll just say this. If you happen to be in the North Carolina area, please track him down. You'll be glad you did. Like I said, I read his reviews. I went online on his website and read his reviews. Believe me, if you're in that area, it will be worth your while. Make sure you're 45 and over. Go see him for your, call his office, make your appointment for your colonoscopy and everything. If you're having these issues that he's described, please make an appointment. The rest of us, please see your doctor, and it's your health. Take charge. Most of us have insurance that we don't even use. You pay for it, take advantage of it, and save your own life. So thank you, Dr. Nunoo. We really appreciate you.
You're welcome.
Add that if you happen to be in Ghana and you need it, go to Pleasant Medical Center.
Yes.
Yeah, definitely.
Yes, so yeah, I put up the 2 takeaways, saying that, and I'm glad you remember them. That is the colonoscopy thing that really saves lives, and also the fiber. I've seen, I recently had a patient who he got his colonoscopy and had a very big polyp that they couldn't take out with the colonoscopy, and we all initially thought it was cancer. So when he came to see me, he had surgery, and we took out that part of his colon, believing that there was a possibility that this thing could harbor cancer. And it came back as something we called high-grade dysplasia, which means that it is as close to cancer, but it wasn't cancer. In 6 months, that would have been a cancer, So he just had his colonoscopy at just the right time, because if he had it 6 months later, we'll be calling it something else, and he might be needing chemotherapy, So just get your colonoscopies. Yes, there's some risk that comes with them, but they are small, and I think the benefits definitely outweighs the risk. And then just stay on your fiber. And then the last thing is, if you know anybody who is in Ghana and needs surgery of some kind, please go to Pleasant Medical Center. We'll be there 21st of, we're actually arriving on the 22nd, so 22nd of April to the 5th of May. We'll be doing some surgeries there. So please go for screening and see if it's the kind of surgery that we can do whilst we are there. So thank you all very much.
All right, thank you so much. And thanks to everybody else, everybody as well for tuning in. Without you, this program is useless. So thank you for your time. Pro, as always, thanks for providing the platform. Without you, we don't get to do these things. So thank you so much. One last word, Pleasant Medical Center. You want American type of healthcare for your family, Pleasant Medical Center. If you contact me personally, I will show you how to get in touch.
And don't forget to ask for the Santaclausian discount.
That's right. But thank you all so much.
Yes,
and have a good night. Good weekend as well.
Thank you.
Yes.